Hello and good evening, everyone. Welcome back to our IVF webinar once again. It's a Tuesday evening, and I'm very happy that we are starting with our first webinar tonight at 6 p.m. UK time. And as you probably might have seen, there is another webinar coming up at 8 p.m. UK time. So there are two events tonight. And I'm very pleased to have you here once again. Dr. Daniel Bodri is with us. Hello, Dr. Daniel. How are you feeling? Thank you so much for joining us once again.
Thank you, Caroline. Thank you very much. I'm feeling very good.
Glad to hear this. And I'm so happy that you are here. There was a bit of a mishap with the hours, but actually we are here. So don't worry, we are here to support you. And we are here to discuss an interesting topic, some topic that I think that recently is being more and more discussed. And I think that is very, very important that we are still talking about this. It's fertility preservation for women. And I know that this is something that that's always, I think it's still something that is not done everywhere. So that's why I am even more happy that we are able to mention this, that there are options. So if anyone is wondering if they can, let's say, postpone pregnancy, there are some possibilities, there are some ways that we nowadays can actually use. So why not use it then? Of course, today Dr. Bodri will tell you all about this. He will explain how it works, how it's done, and when it's actually, of course, as well indicated. So as always, we will start with his presentation on our topic, and afterwards it will be time for your questions. So don't forget to type the questions in the chat section, and then Dr. Bodri will definitely answer them for you. And remember, it is being recorded, so I hope not, but if you need to leave at any point, you will be able to check the recording. It will be available tomorrow on our site as well. So yeah, let's get to it. Okay, Dr. Bodri, ready to start with the presentation?
Thank you, Caroline, for the kind introduction. And it's really a great pleasure to be invited by my IVF Answers again to talk about fertility preservation for women. Mainly about egg freezing with the relatively recent method of vitrification.
Exactly. So, thank you so much. And sorry, I haven't mentioned yet, but you will see that actually Dr. Bodri, he's the Gynaecologist Fertility Specialist, of course, at IVF Spain. And I'm very pleased to have you back. If you haven't seen, he was with us before, and I can already tell you that he will be back. There are some webinars, I believe, webinars in July scheduled with you. So let's get to it. Let's go ahead with our presentation.
Thank you, Caroline. So before starting, I would like to give just a brief introduction about myself. I was trained in the assisted reproduction in France and in Spain, and have obtained a PhD and an MSc from Barcelona and Leeds universities, respectively. I had quite an international working experience by working in renowned clinics in Spain, Japan, and United Kingdom regarding social freezing, both in United Kingdom in London and now in Spain. We had quite an interesting experience in two different countries. I'm also interested in research and egg donation, embryo transfer procedure, and personalized stimulation protocols are my main fields of research interest. This is the outline of today's talk. So I would like to give you a brief introduction and talk about the biological rationale of egg freezing. Then we would discuss the main indications of egg freezing and discuss what is the ideal age for social egg freezing. Then I will talk about the efficiency of the whole procedure. We could answer the question, how many eggs are needed to have acceptable results with frozen eggs. And then I will walk you through the whole process of ovarian stimulation, egg collections. We would discuss risks and side effects, and we would also talk about some practical considerations. So let's start. Actually, egg freezing is not a very recent method. Already some 3 years after the first frozen embryo was produced the pregnancy, a researcher has managed to freeze eggs in 1986 with still a less efficient slow freezing method. And however, egg freezing really took off when a much more efficient ultra-rapid method of freezing, the vitrification, was discovered or put into everyday practice, practically from the early 2000s or mid 2000s onwards. The HFEA in the UK allowed treatment with frozen eggs in 2000. Somewhat later, in 2013, also the American Society lifted the experimental label. And since we have witnessed an exponential increase, especially in social egg freezing. This graph shows the evolution of egg freezing cycles, both for medical and for social indications in the UK. From the latest data from the HFEA, you could appreciate that the below line shows a relatively less important increase for medical indications like cancer and others. We will talk about it. But there's really an exponential increase in social egg freezing, reaching almost 1,500 cycles in 2016. And since we have definitely even more cycles. This increase was basically done in private clinics because in the UK there's a dichotomy between NHS-funded and private clinics in terms of indications, as you can see. The picture is similar in Spain. This is registry data from the Spanish Fertility Society. And you can see here that with own eggs, the number of cycles was also steadily increasing, reaching more than 6,000 cycles in 2018. One could see that these egg collections involving own eggs, it was 15% of the cycles that were social freezing cycles or egg freezing cycles. And with similarly, with oocyte donation, more and more cycles, all the eggs or part of the eggs were frozen too. So basically there was a sort of switch from fresh to frozen eggs in oocyte donation treatment in Spain. There are still clinics like our clinics too who do in the majority of cases fresh donor eggs, but also frozen donor eggs is a possibility. So from this we could draw the conclusion that in Spain, where most of the egg donation cycles does involve egg freezing, those clinics that have large oocyte donation programs and donor egg banks, they have a quite important expertise in the vitrification method itself. And this gives an assurance to patients that when they freeze their own eggs, the outcomes would be very good. So let's talk a little bit about motivations of potential egg freezers and their typical profiles. I encourage everybody to read the articles of Zeynep Gurdin, this excellent social scientist who investigates many aspects of assisted reproduction and especially has done quite a lot of research in the motivation of social egg freezers. These are very informative and interesting articles in The Guardian. And we could, based on this research and our experience too, we could distinguish different profiles. There are the early or young egg freezers who are often even in their 20s or usually in their early 30s. These are very well-informed, proactive planners, women who prefer to invest couple of thousand of pounds in freezing their eggs while young, have a good amount of good quality eggs so that they can fully concentrate on their professional goals. There's also another group of late freezers in their late 30s or early 40s. These women are already very much aware of the decline in their fertility, and mostly they are single. They don't have still the ideal partner with whom to found a family. So by freezing their eggs, they're buying a few extra years to find this ideal partner. As we know, there's a lack of eligible men who could be ideal partners. And if this enterprise is unsuccessful, then often they choose the solo motherhood route. And we also have seen egg freezers in heterosexual relationships who do have a partner, but maybe the partner is not ready, doesn't want to have children, not committed enough, too young or too old, maybe already has his own children from a previous relationship. And another group of patients, maybe recently divorced or separated women who freeze their eggs for a potential future second relationship. What is the biological rationale of egg freezing? Obviously, it's a very well-known fact that the quality of eggs and their chromosomal composition gradually declines with advancing female age from the age of 35 exponentially. And this is the reason why there are these aneuploid eggs and also embryos that are created from these eggs, which is the explanation why live birth rates are decreasing with advancing female age and miscarriage rates are increasing either in spontaneous conceptions or after IVF. So let's talk a little bit about the main indications of egg freezing. We all know that there are the classical social and medical indications. Actually, social egg freezing has other synonyms too. For example, elective or planned fertility preservation. There's also the prevention of age-related fertility loss, which this concept emphasizes that it's not so much a social, but also could be regarded as a medical indication, and it is within the scope of preventive medicine to freeze eggs at an earlier age when they are better quality. In the UK, there's also this very interesting freeze and share scheme, which allows in those women who also consider altruistically donating their eggs, donating these eggs, if they are, of course, below the age of 35, donating these eggs and in exchange with a discount in the treatment of freezing their own eggs. Then there's, of course, the classical medical indications. For example, before oncological treatment, breast cancer or hematological malignancies. In this case, often it is urgent to proceed to ovarian stimulation and freeze eggs before chemotherapy and radiotherapy is initiated. Nowadays, there are protocols which allow practically to start treatment immediately after the diagnosis have been made. But there are also other benign gynecological diseases, for example, severe endometriosis or benign ovarian tumors that could destroy the ovaries. And in this case, it is a medical indication to freeze eggs. In some cases, with severe autoimmune diseases, before the treatment could damage the ovaries, it is recommended to freeze eggs. And there are also some genetic conditions, Turner syndrome or the history of premature ovarian failure, when it is recommended to freeze eggs before the ovaries are exhausted. A new indication which is emerging is for transgender patients, female to male transgender patients who could freeze their eggs before the gender reassignment therapy is initiated. There are also some other situations when egg freezing could be done. For example, the clinical egg freezing when for low responder patients who have a low ovarian reserve and produce a few eggs, less than three or three, around 3 eggs. In this case, it is possible to do several stimulation cycles, accumulate the eggs, and only fertilize them when there is a sufficient number to do fertilization, embryo culture, and submit the resulting embryos to pre-implantation genetic testing. In this case, for example, the cost of the IVF treatment itself, the laboratory part, with fertilization and embryo culture, or PGT, is only incurred once when, from previous cycles, the suitable number of eggs have been already obtained. Then there are also some unexpected scenarios during an IVF treatment when egg freezing could be practiced. For example, when there's no sperm available unexpectedly on the day of the egg collection, and in this case, we have no other option but to freeze the eggs and thaw them later and fertilize them later when sperm will be available. Or we have also seen this so-called partial egg freezing. For example, too many eggs are produced, and in order not to create too many embryos, with all its ethical implications, some of the eggs could be frozen too. What is the ideal age to do social egg freezing? If we look at the guidelines from different countries, they are quite concordant in indicating an ideal age of below 35 or below 38 as the ideal age to freeze eggs. For example, the guideline from the UK acknowledges that there are still many women who decide to freeze their eggs above the age of 40, and in this case, the likelihood of pregnancy is much lower. And for example, the European guideline of the ESHRE also contemplates that there's an age limit to use the egg, preferably before the age of 50. Now let's talk about the efficiency of the whole process. So how many eggs we need so that we can have a good result with social egg freezing. We could use this counseling tool from Goldman and colleagues from the US. They managed to, or they tried to establish this counseling tool by analyzing all of their IVF cycles from their center. We should emphasize that this is not real life data from actual social egg freezers, but more an extrapolation of IVF pooled IVF data. So we can see that the number of potential eggs can range from 0 to 100, which is of course an impossible number. But if we look at, for example, 20 eggs, then we could see that in case of patients, this is a quite detailed age breakdown. Patients who are less than 35, the chances of pregnancy with 20 eggs are very good chances of a live birth, 90%. Then it gradually declines. For example, with a 38-year-old patient, it's only 70%. And above 40, we are in this territory. So we could see that the chances of pregnancy are much lower, ranging from 50 to only 15%. So this is quite a sobering picture. We could see that the curves are much flatter for the ages of 40 and above. Another publication from Spain. This is the largest available publication on social egg freezers involving some 7,000 cycles. This is actually real-life data, and it is very useful for counseling. We can see that in this publication, there are two age groups, less than 35, the blue line, and above 35, the green line. So we can see that the chances of obtaining one live birth ranges from 16% if somebody has 5 eggs, up to 94% if somebody has 24 eggs frozen in young patients who are less than 35. You can see that the blue line is steadily increasing. In comparison with older patients above 35, if we have 5 eggs, then the chances of the pregnancy is only 6% live births actually, cumulative live birth rate, and it increases with 20 eggs up to 50%. So it's a lower chance, and then we see that the curve plateaus. So this is sort of a maximal cumulative live birth rate that we could expect for older patients. So there's often this number of 15 to 20 mature eggs. The expected results, of course, largely depend on age. One should always also consider that if somebody wants more than one child, then even more eggs might be needed. But in any case, any amount of frozen eggs is better than to have no eggs. So I would like to introduce you to this concept of the IVF funnel to show you that what happens, for example, for two different patients, hypothetically, somebody who's less than 35 years of age or an older patient. Let's imagine that a younger patient did manage to freeze 16 to 20 mature eggs. When these eggs are thawed, the average survival rate for a younger patient is around 90%. So maybe 1 out of 10 eggs might be lost to the thawing procedure, and we would end up with 14 or 18 thawed eggs. These eggs are fertilized, and then with a 70% fertilization rate on average, we could end up with 10 to 12 fertilized eggs on day 1. Then embryo culture is done until day 5-6 of the development, until we have obtained 46 blastocysts, because the blastocyst formation rate on average is 40 to 50% in younger patients. And if we implant these embryos one by one, then with a 50% live birth rate, taking into account failed embryo transfers and miscarriages, we could expect 2 to 3 live births, which is an excellent outcome. In comparison, in an older patient, already an older patient might not be able to produce this 16 to 20 amount of eggs. So I have put 8 to 10 eggs. If the sowing, which is a slightly lower, around 80%, the survival rate, then we could have 6 to 8 thawed eggs that have survived. After fertilization, we could obtain 4 to 6 fertilized eggs on day 1, and then 1 to 2 blastocysts, because the blastocyst formation rate and the live birth rate is also lower, and we could have, in a best case scenario, 1 live birth if we're lucky, or maybe no live birth if we have started only with 8 to 10 eggs. So this funnel shows that even if we have a certain amount of eggs, until we have blastocysts and live births, of course, the numbers would decrease. So there's no absolute guarantee for a live birth with social egg freezing. We should counsel the patients about this fact. Let me introduce you a little bit, present you some data regarding our own experience in IVF Spain in the Alicante clinic. So these are some demographic and cycle data from egg freezers from the last 2 years. You could see that their mean age is relatively young, 35.8, but maybe it's more interesting to look at the age distribution. We could see that patients in their 20s are 15%, early 30s 32%. So these are the best age categories to do social egg freezing. We still have 36% of egg freezers in their late 30s, which is still acceptable, and we have some 17% of patients in their early 40s who have probably a diminished success rate with social egg freezing. As expected, we could see that more than 80% of the egg freezers are highly educated white-collar workers. Most of them are single, but some of them are in a heterosexual or lesbian relationship. Only 5% of them have children, which is understandable. And what is very interesting in our clinic in Alicante, that attracts a lot of patients from abroad. Up to 73% of our patients were cross-border reproductive care patients, meaning that they came to freeze eggs from another country. Only 27% were Spanish. The number of egg freezing cycles performed by patients was about 1.5. This is maybe a little bit low because we would recommend to have on average at least 2 cycles or maybe even 3 cycles per patient so that we can obtain, for example, this target number of 16 to 20 mature eggs. How many eggs were obtained? The total number of eggs was on average 11.2, and the number of mature eggs was 9. So this was the average amount of eggs frozen from one cycle. One should distinguish between total eggs and mature eggs. Normally, around 78, 80% of the total eggs are mature, and only mature eggs are freezable. So it's only always the number of mature eggs that is the definitive end result of an egg freezing cycle. We see that if we freeze 9 eggs approximately, then we need at least 2 cycles to reach a suitable number. So why we have so many patients who are coming from abroad? If we look at the situation of egg freezing in Europe, we could see that there are countries like Spain or the UK where it's a well-established practice. You have seen the results from the registries. But there are some other countries, for example, some countries that even don't allow social egg freezing. This was the case until recently of France or Hungary or Norway at the moment, where the social egg freezing is not allowed because it's judged experimental. And there are also countries where the access to any fertility treatment is not allowed for single women, who are obviously the prime users of social egg freezing. In other countries, for example, where the fertility treatment is usually done in public centers, some of these centers do not regard social egg freezing as a real indication of infertility. And in this case, if there's no private clinics who do this kind of treatment, then patients don't have any other choice but to go to abroad to do this kind of treatment. And in some cases, this is simply not something that is routinely offered, or it's a too costly treatment. For example, we will see some countries like in the UK where it's quite expensive to freeze eggs. So how the whole process of the egg freezing is done. This is practically the scheme that we follow at our clinic at our clinics with the IVF Spain group. We have a first contact, a first consultation, which is nowadays usually a Skype consultation. Then we have some initial tests that could be done also at the home country of the patient, a scan and blood tests. Then ovarian stimulation starts, which is a 2-week treatment. And this could be started in the home country of the patient herself, and then maybe the patient only has to come for a period of a week to Spain, where she can complete the monitoring and do the egg collection and freezing of the eggs. So what are the tests, necessary tests before starting egg freezing? Basically, apart from some blood work, which includes infectious screening tests, blood count, or clotting tests, The most important test maybe is to evaluate the ovarian reserve, which is done with a hormone test. The AMH level, the level of the anti-Mullerian hormone is determined. And also we count the number of follicles on a baseline scan, usually at the beginning of a menstrual period, to see how many potential eggs we could expect from a successful ovarian stimulation. Even, these numbers are very helpful to predict the possibility of an ovarian response, but it's really the stimulation itself that will give the definitive answer about the outcome. What kind of protocols of stimulation do we use? Nowadays, we practically always use the short protocol with the GnRH antagonist, which is a convenient protocol that lasts a little bit less than 2 weeks. And in order to avoid any kind of ovarian hyperstimulation syndrome, we use the so-called short-acting triggering agent, which is a very safe and convenient option. Egg collection is done under conscious sedation. So this is a 15-20-minute procedure, and basically the patient would sleep during the intervention and wouldn't feel any pain or any inconvenience. After a 1.5 hour observation, the patient could go to her hotel, and after 24 hours staying in Spain, she could already fly home after the egg collection. Vitrification is done with a Japanese method, which is the most efficient method nowadays to freeze eggs or embryos, and the survival rate is expected to be approximately on average between 80 to 90%. So in younger women, it could be as high as 90 or 100%, and in older women, if the egg quality declines, sometimes the survival rate might be lower. So it is possible to lose 1 or 2 out of 10 eggs at the sowing step. What are the risks and side effects of the stimulation? There are some common side effects like lower abdominal pain, discomfort, swelling, breast tenderness, mood swings. These are temporary side effects present usually towards the end of the stimulation and a couple of days after the egg collection, but they are temporary and would quickly disappear after egg collection within a week. Any more serious side effects? Practically, we could now say that ovarian hyperstimulation risk is eliminated because of the type of the protocols that we use. There's some small risk of an intra-abdominal bleeding. Sometimes a small vessel could be damaged on the surface of the ovary, but if this happens, it's quite rare, less than 1 in 1,000 cases, and usually this could be managed conservatively without any surgical intervention. In terms of long-term side effects, ovarian stimulation is not demonstrated to have any effect on future fertility or ovarian reserve. It could be repeated. And that's why we recommend after a short pause, 1.5, 2 months, maybe to restart another stimulation cycle and do 2 or 3 stimulation cycles until we have the suitable number of 15 to 20 mature eggs. There's still limited data on safety of vitrification procedure itself regarding the offspring, limited published data, but we could be quite confident that it's a safe procedure because there are many children born from egg donation using frozen vitrified eggs, and so far we haven't had any evidence of increased risk. Of course, these children should be followed up during several years to have a definitive answer on that. Let's talk a little bit about practical consideration like the cost. So this is a little bit of information from the internet. You could see that prices vary quite largely depending on the country. These are the average prices in Spain. Actually, in our clinic, you could see that the price is a little bit more on the lower side. And actually, at the moment, we do include 5-year storage fees. We waive these fees for those who freeze their eggs. This process is much more expensive in the UK, on average £7,000-8,000, and the cost is really important in the US. That's why we often have patients who come over to Spain to do egg freezing. What happens if the eggs are not used? This could happen to especially patients in their 20s or early 30s who have a high possibility of conceiving spontaneously. So if eggs are not used, then they could be donated as long as they have been frozen before the age of 35 years. They could be also destined to research or training, or simply discarded. It is much more easier to discard actually eggs than embryos. So freezing eggs does have this kind of advantage. Also, there are no parentship issues because frozen eggs are only the propriety of the patient herself who freezes the eggs. Eggs could be also transported to other centers. It's quite straightforward between EU countries, a little bit more complicated now because of the Brexit with the UK or for example, countries like Switzerland. And it's quite costly if it's done overseas. In any case, these are specialized transport companies who do the transport and charge accordingly. How to choose the best clinic for egg freezing? These are some of the criteria that one could look at. Of course, it has to be a well-established center because eggs might be frozen during several years. Especially the experience of the lab with vitrification is important. And if the clinic has a donor egg bank, this is a good sign that the lab itself is proficient with vitrification. And of course, if the clinic is well-staffed and has a non-stop operation, logistically, it's a positive thing in case of monitoring and scheduling the egg collection. Our clinic in Alicante, the headquarters, is such a clinic. We have 3 operating theaters, an excellent lab team, 2 embryology labs. We also have our own genetic department. So for any kind of test that is more complicated, like preimplantation genetic screening or endometrial receptivity assay, we can do it in-house. This is our medical team. Probably we have the most multilingual team in the whole of Spain. You could see the languages that we speak here, and a very experienced team with experience in handling cross-border reproductive care patients. Our group has 3 clinics in Spain, headquarters in Alicante, also in Madrid, and in the northern part of the country in San Sebastian. And we also have 2 branches in Germany, Baden-Baden, and in the UK in Manchester. So we will be happy to receive you as for egg freezing or other treatments in any of our group's clinics. Thank you very much for your attention. And now I'd like to switch to Caroline to go ahead with the second part of the webinar. Thank you.
Perfect. Thank you so much indeed, Dr. Bodri. That was definitely very interesting, useful, lots of details, but it's amazing to see how what the possibilities are. So thank you so much for providing us with this. And now, as you all know, it is time for your questions. So if you have any left, go ahead, though, to type those in the chat section. Sorry, there is one of the questions that I see here, and let's have a look at this. Lisa has asked this question. So do you also have patients who decide to freeze eggs because they are trying to conceive and it's been unsuccessful for some period of time with their partner? Or would it be better to freeze embryos? Interesting question. Thank you, Lisa, for that one.
Yes, thank you very much. This is a very good questions. I didn't talk about that. For example, comparing the advantages and disadvantages of freezing eggs versus embryos. Embryo freezing is another option of fertility preservation for couples. So one obvious difference, if embryos are frozen, that a sperm sample is needed to fertilize the eggs. This could be partner sperm or donor sperm. And also that freezing embryos is a much more advanced stage in this IVF funnel that I've shown, meaning that it's not the same to have, for example, 16 to 20 eggs compared to 4 or 6 blastocysts. So based on the patient age, the success of a future embryo transfer could be predicted better if you already know how many embryos were created from a certain number of eggs. Egg freezers don't know until they actually submit these eggs to the solving process, fertilization, and embryo culture, how many embryos they would have. But there's also maybe some disadvantages of embryo freezing, because obviously parentship issues. So this is both partners have equal rights and could dispose differently of these embryos in case, for example, a divorce, separation, or even death of one of the partners. And also the cost is different if somebody freezes eggs or freezes embryos, because if embryo freezing is done, then practically the whole IVF process need to be done.
Right, understood, of course. Thank you so much. As I mentioned, definitely interesting question. So there are like different things to look at this, yeah? So I guess it has to be done personally, because every case is different. So thank you so much indeed for this. Okay, let's have a look. Okay, Lisa has one more question. So if I want to freeze my eggs, how many eggs do I need to freeze? Is there a difference if someone is 35 versus 41? I am 36.
Definitely, there's a difference. Definitely. So, I mean, if you're 36, you're still presumed to have a good egg quality. Basically, some of the guidelines talk about egg freezing before the age of 38 or before the age of 35. But we have seen in this publication of Kobo and colleagues that at 36, the chances of the pregnancy are quite good in case a good amount of eggs is frozen. So this could be ideally up to 20 mature eggs, gives you probably a chance of 75-80% of having a live birth. So the more eggs, the better. Of course, this has cost implications. It depends largely also on ovarian reserve markers. What is your AMH and the number of ventral follicle counts on a scan, because some patients who have a high ovarian reserve, they might be able to produce a number close to 20, even from one stimulation cycle. But stimulation cycles could be repeated. Yes.
Excellent, wonderful. Thank you so much, Lisa, for adding that and for your help, Dr. Bodri. One more question from Derek. What % of social freezing do you have at your clinic?
Well, it depends basically on each clinic. I mean, in the Alicante clinic, we do have a high proportion of patients who are coming from abroad. I would estimate it maybe like being like similar as in the statistics in the Spanish Fertility Society, something about 12 to 15% probably. It is definitely increasing, and basically we expect to increase it to up to 20% possibly of the cycles with own eggs.
All right, of course. Thank you so much, Derek. That's again interesting. So you can see an increase, I understand, when it comes to egg freezing. Well, that's definitely good to hear. That means that I guess women are more and more aware, and they are deciding to go ahead with it. So thank you. Let's have a look. Okay, Lisa has one more question here. What is the best age for egg freezing according to doctors? What age would you not recommend freezing?
Yes, thank you very much, Lisa. So basically, less than 35 is an ideal age, but even 36 to 39, so patients in their late 30s, it's acceptable to freeze eggs. So the only group maybe where it's a little bit more counseling is needed, and we have to explain a little bit the expected success rates are patients above 40 or above. So we have requests. You have seen that it was like approximately 17% in our recent experience patients in the early 40s who did still egg freezing. I mean, our approach that any egg is better than, any amount of eggs is better than no frozen eggs. The other alternative in this case, for older patients is oocyte donation, which is always readily available. But if somebody contemplates egg freezing at the age of 40, then it is still could be done.
Right. Again, thank you so much, Lisa, for yet another interesting question, of course, and thank you for answering. At least at this point, I don't see more questions. So if we do not have any more questions, we will be finishing. However, I would like to thank everyone already for joining us tonight. I definitely think it was useful. And as you know, if you don't have questions now, remember that you can get in touch with Dr. Bodri and his team at IVF Spain. I am more than sure that they will be able to help you out as well with any questions that you might have. So you can use the link, but as always, there is an email that you can use, and I'm sure they will be happy to help you out. There is one. Thank you already. Thank you. Great presentation. Dr. Bodri from Derek. So as we do not have more questions, please let me know if there is anything you would like to add before we finish, Dr. Bodri.
Thank you very much. It was really interesting to collaborate with my IVF answers again. And for any patient who has a question, please send an email to us, and we would be happy to have a conversation with you and explain all the details. Thank you very much.
Amazing. Thank you so much. And as you can see, Lisa has added as well. Thank you for answering my questions. Really useful. Great presentation. Glad that it's helpful. And as you know, today we do have another webinar at 8 p.m. So I hope you will be able to join us. Monica Bivas will be with us. And of course, she will discuss coping mechanism when it comes to IVF journey. So if you wish, let's connect at 8, and I'm sure it's going to be, again, useful for you. And as I mentioned, Dr. Bodri will be with us in July. There are 2 webinars scheduled. I don't remember the exact dates, but you can always go to our My IVF Answers website, and there already. And of course, Dr. Bodri, it's always great to have you. Thank you so much. So I am very happy that we will have you back. So see you very soon. Everyone, have a lovely evening. And again, it's been great to have you all here. Thank you so much. Take care.
Thank you so much. Bye-bye.
Bye.
Thank you. Thank you.